Good morning, and thank you for joining us for our webinar on Physician Leader Performance Reviews. My name is Vicki Radcliffe, and I'm going to be your moderator today. Before we get started with our presentation, I'm going to review a few basic reminders and instructions just for our audience's knowledge. First, if you are having any issues getting online into this presentation, please call the Integrated Healthcare Strategies front desk, and they may be able to assist you. That number is 612-339-0919. Again, if you're having any trouble logging or calling in and would like some assistance, please call our front desk at 612-339-0919. Please be aware that all participant lines will be muted for the entire presentation in order to reduce noise and distractions heard on the line. At the end of our presentation, we're going to allow some time for questions and answers. If you do have a question you would like addressed, you can type it in and we will read it off for you. To do so, you'll click on the Q&A button that you see at the menu bar at the top of your screen. Simply type in and submit your question, and we'll do our best to make sure that it does get answered. Finally, all participants will receive a copy of today's presentation following the webinar, so you can look for that in your email box shortly after our webinar today. Our presenters today are Jim Rice and Kate Brecky. Jim is Executive Vice President of our Governance, Leadership, and Executive Compensation Office, and also is the Director of the International Health Leadership Program at the University of Cambridge in England, and also serves as the Vice Chairman of the Governance Institute. Kate is a consultant also with our Governance, Leadership, and Executive Compensation practice. Now I'll go ahead and pass it off to our presenters to go ahead and begin our webinar.
Thank you, Vicki. Welcome, everyone, to this fifth in a series on physician leader alignment and physician leader effectiveness development. We have conducted 4 previous webinars, one on factors that facilitate and factors that frustrate physician leadership effectiveness. A second one was conducted on the competencies that are essential for physician leadership. The third was on an examination of 10 physician leadership academies that have been quite successful across the United States, and a recent one on the physician leadership style that is so important for building and nurturing interpersonal relationships within their hospitals and hospital systems and large medical groups. Today we're going to be moving forward in our journey to look at how physician leadership alignment is going to be critical to physician alignment in general. On slide 3, you'll find a journey moving from left to right, where several years ago we would be focusing our activities in hospitals and healthcare systems on delivering a superior patient experience in a 15-minute encounter. Over the last several years, and particularly now, we're focused in the middle of this slide on the 15-day episode. And as we have been moving from 15 minutes to 15 days, the shift of our focus of revenue and patient care has moved increasingly from approximately 70 to 80% inpatient to today, where many of our hospitals are focusing on 50-50 inpatient and outpatient balance. Where we believe the health field is going, particularly with the health reform legislation that's been enacted and the new priority focus on accountable care organizations and bundled payments, is a recognition that with chronic disease, we now must look at 15-year relationship, and physician alignment across this spectrum of involvement is critical to our success, both economically as organizations and certainly in our mission toward community service. And I think one thing to take from this slide then is that this journey will require physician alignment. Along the bottom you'll see diversity, uncertainty, tension, and now if you look at the far lower right-hand corner, the premium is going to be placed on those organizations that create a culture that is patient-centered, performance-driven, values-based. All of that requires physician alignment. This recent study by the advisory board looking at the implications of the new health reform law and the pursuit of accountable care organizations, and bundled payment, looks at this journey from a different perspective. The movement from left to right suggests, again, another reinforcement for physician alignment is the movement of the economics to encourage us to have aligned economic incentives. That is going to require not only good physician alignment, but a whole new generation of physician leaders. Reinforcing that on slide 5, you'll find that the studies by SG2 look at a wide panorama of physician-hospital relationships, moving from the traditional medical staff on the left to high integrated models, which are going to be critical for the new ACO environment we're going to find ourselves. So again, we see reinforcement for not just physician alignment, but physician leadership development. And one of the concerns about the array of relationships that we see in slide 5 is a patchwork quilt that is really very difficult to govern. And we had an article coming out this fall in the ACHE Journal on some practical strategies to govern this new relationship array that we find. Physician leadership, again, is critical to that. On slide 6, you'll see an illustration of 10 dimensions that we are using to guide our development of webinar series and studies that we have been conducting over the past year on physician leadership. Today we're going to be looking at one particular, very narrow focus on that, and that is the slice numbered 8, which is performance reviews. We are finding with our clients and in our studies that it's very difficult to embrace a new modern talent management approach to physician leadership development unless all 10 of these dimensions are present. Today we're going to spend a few minutes drilling into the area of performance planning and performance appraisal for physician leaders, and in particular we're going to be looking at some findings in a study that has just been completed in the last couple of weeks about what are hospitals doing to increase their effectiveness at developing physician leaders by embracing some new approach to physician leadership performance planning and physician leader performance appraisal. On slide 7, you'll see that there are 12 key roles that are essential for effective physician leaders to play. It's our premise and a message out of this webinar that physician leadership appraisal must assess the degree to which these leaders are doing well in discharging their responsibilities in these different areas of accountability, and how will that be linked to bonus and recognition and reward programs. The competencies that we have referenced in previous webinars and a website to look at the wide array that all healthcare leaders must embrace are shown on slide 8. The real challenge for all of us, however, is to understand how do we assess the degree to which these competencies are present in our physician leaders. How should we build this embrace of competencies into their job descriptions, if they even have job descriptions? How do we build competency-based performance reviews, and how do we link this to incentives and recognition? That was the backdrop and the context in which we decided to go out to the field and talk to senior leaders to identify what are they doing to assess physician leader performance, how are they building performance appraisal processes, and it's this study that we are now going to try and summarize some of the findings for you. Kate Brecky is going to help us understand some of the conclusions reached from this, and then we'll have a chance for questions and answers near the end of our webinar. Kate, thank you for taking the lead on this national study. Please take a few minutes and summarize some of the findings that we've had from that inquiry.
Thanks, Jim. And as you mentioned, we just wrapped up the survey not too long ago. We had 90 physician leader respondents replying to the survey that we sent out, and they came from various organization types, including standalone hospitals, system hospitals, integrated health systems, and medical groups. So if you look at the chart towards the bottom on slide 10, 39% of the respondents came from executives at standalone hospitals, and 21% came from executives of a hospital system. 17% came from a hospital that's part of a larger system, and then 11% of the respondents were from a medical group, and 3% from integrated delivery systems, and then 9% from other types of organizations. One of the first questions that we asked was what the physician leader positions they had at their organizations were. And one of the most common was the chief medical officer on slide 11. 74% said that this was a common position within their organization and existed in their org chart. 72% said that they had a medical director of emergency services. And 64% said that they had a medical director for a clinical line. 60% of the respondents indicated that they had a clinical department chair, and 37% indicated that they had a vice president of medical affairs. And looking at slide 12, more of the less common type leadership positions at organizations included medical directors for quality and safety, medical informatics, medical education, clinical research, and referral outreach services. And of course, as the landscape changes for our healthcare system, so will the numbers of physician leaders in all of these positions we've just mentioned, some of them gaining more momentum than others. And in fact, if you look at slide 13, the medical executive of clinical integration is one that we've seen increasingly being added to organizations even in the last 3 to 6 months. And these three listed on this slide were identified by respondents as additional positions within their organizations that we had not outlined in our actual survey. On slide 14, we then asked in the survey the percentage of physician leaders who receive an annual performance appraisal. And this is sort of a difficult chart to follow, and I'll explain the outcomes in a couple different ways in order to grasp it. But if you look at the first line, almost 56% of systems conduct reviews on only 20% or fewer physician leaders in their organization. And that's somewhat of a startling number we found. Alternatively, if you look at the bottom line, organizations that provide appraisals for at least 80% of their physician leaders only happens at about 23% of the organizations that responded.
Kate, it's clear from this study that this is disturbing as a finding because just at the time we need more physician leaders, we have very few hospitals doing a very good job on doing performance planning and performance appraisal, at least from what we can tell from this national survey.
Absolutely, and our hope is that the industry, flips this in the next 2 years, where the majority are reviewing all of the physician leaders that exist in their organization. And actually, this comes up quite a bit. It really becomes an IRS issue. For example, they come into an organization and say, what are you doing around best practices in governance and executive compensation? And your organization wants to be able to respond to that and say, we're doing these particular activities and pursuing these particular responsibilities around good governance, and you want this physician leader performance appraisal to be one of those items that you can list. As a follow-up on those that actually do conduct appraisals, we then asked the effectiveness of their current process. And if you look at the first couple of lines, 50% on slide 15 are saying that it's in the low end of the effectiveness scale, the actual performance appraisal that they're doing. And then if you look at the last 3 lines of that chart, 50% are indicating that it does have some level of effectiveness.
Well, it looks like we have few doing it and few doing it well. So what are some of the obstacles to embracing a more effective look at physician leader appraisals?
Well, yes, that was our next question. We asked what are common obstacles in the effectiveness of their organization's physician leader appraisal process. And one of the most frequently cited common obstacles was the lack of an effective appraisal tool. And 53% cited this. This was followed by a lack of training in conducting the appraisal with 49%, And then inadequate metrics of performance, 46% cited as a common obstacle. Lack of education on the value of the appraisal process was cited by 44%. And then unclear position descriptions was cited by 38%.
I think we'll need to come back to that fourth one, lack of education on the value. I think in our interaction with clients, this is a very important challenge. Physicians don't understand why someone should look over their shoulder, even if it's in a supportive or coaching manner, to look at how they are performing their work. It's, again, an encroachment that is going to be a challenge for all of us to wrestle with.
That's a good point, and a theme that we hear over and over again with our clients or from our clients as we're working with them in this area. Slide 17 has additional obstacles that were identified, those being disconnect in appraisal process to actually drive growth and development of the physician leaders. There's the absence of a link between the performance appraisal and the incentive plan. This was an obstacle cited by 36%. Lack of willingness to participate in the process. Again, this is something that, while only 21% cited this, it's something that we hear with our work with clients quite often. Weak organizational buy-in of performance appraisal process, and then time intensity.
Here, Kate, on slide 17, the fourth one, the organizational buy-in, if the chief executive and the senior executive teams aren't enthusiastic about their own performance appraisal, it's very difficult to see how you'll have a culture that recognizes and rewards physician leaders for going through that same rigor.
Absolutely. It takes the CEO and the senior leaders to understand the significance of this process to really drive it throughout the organization. On slide 18, we outline some of the common methods respondents indicated they include as part of their performance appraisals. So the first one cited by the respondents was having a clear job description reviewed as part of the review process. And this is a positive finding within some of these other negative findings, that respondents understand that job descriptions are understood to be an important piece of the appraisal process, but even this number is dropping a bit into the low performance zone. Some others cited as a current method include the review of annually established goals. 61% cited this. Establishing future years' performance metrics used for bonus and merit pay was also included. Discussion of leadership development opportunities, self-assessment, and meetings with leadership mentor were also included.
I'd just like to call the audience's attention to the very first one. The lack of clear understanding of expectations of these physician leaders is a big, big issue. A year ago when we did a study on what are the factors that facilitate or factors that frustrate physician leadership effectiveness, the largest one identified was this lack of a clear expectation of what they're supposed to do, how they're supposed to do it, where they're going to get trained to do it, what kind of support they're going to have, and what is the value to them and to patient care. So we can't overemphasize this obstacle enough, or as a positive strategy to be embraced for success in the future.
Mm-hmm. That's a great point. Slide 19 lists a few more of the methods that respondents identified that they're currently using, which include then a 360-degree review process, regularly scheduled progress reviews with supervisor, structured paper review surveys, and structured web-based review surveys. So essentially, all of these are a bit low, and it would be our hope over the next few years that hospitals pay attention and do more of these things. And really, they have to find a way to flip these findings.
One of the things, Kate, we've found with other leaders, and certainly the administrative executives, is the web-based tool can be a way to facilitate and encourage greater participation in performance planning and appraisal. It's likely that that could have a similar contribution here for physician leaders as well.
Right. It's easy to use. It's efficient. And it takes less time for the users. So that is one strategy in which organizations are adopting in order to drive this process into their organization. On slide 20, we also asked respondents to identify criteria factors that they believe were highly or very important in an appraisal tool. And 97% of the respondents identified quality and safety metrics as a criteria factor that was highly, again, or very important to include. Communication skills, 93% identified this as a highly or very important criteria factor. Leadership and management skills, patient satisfaction scores, and then further down in the chart, participation in clinical process improvement activities, 89% of our respondents identified this criteria factor. And then a few more on slide 21, operations and systems improvement, 85% rated this as a highly or very important criteria factor. Physician morale, physician satisfaction scores also included. Nursing and other health professional satisfaction scores, visioning capabilities, and service volumes were all identified as highly or very important. And we concur with these findings on the last two slides and are glad to see these results, especially, as Jim mentioned, because these are identified factors that are all important in moving an organization into a structure at organizations, whether that's accountable care structures or utilizing bundled payments. On slide 22, a few more criteria factors are identified, and then I should draw your attention to the bottom of slide 22 as other criteria factors were identified by respondents, actually written in by them.
It's clear, Kate, that our participants in this study know what they'd like to assess and what is important for physician leadership development to be focused on and for an annual performance appraisal process to be probing, but still we're finding weakness out in the field, and so let's, in the last few minutes we have, talk about what are the conclusions about initiatives and actions that the participants in this webinar should be focusing in on to improve this situation.
And that was the last question that we did ask of respondents to identify, which was valuable actions in their physician leader performance planning and appraisal process. And these are actually listed in order of frequency cited by our respondents. So this was an open-ended question where we asked participants to actually write in the valuable actions they're using. And then again, they're listed in the order of frequency cited by our respondents. So the first one that was most commonly cited was the clear expectations with the use of goals and targets. So in order to establish those clear expectations, it's the use of identified goals and targets that need to be well laid out and executed. Communication was also frequently cited, and I should add that it's various modes of communication. So, for example, face-to-face interaction, regularly scheduled meetings, one-on-one meetings with counterparts, daily feedback, peer-to-peer conversations, and periodic reviews. And we have to agree, we believe all of these are really extremely critical to the performance appraisal process as a whole.
Kate, on that point, one of the things we found in our previous studies is that physicians not only want to learn their leadership roles like they learn their medicine, and that is standing by the bedside with a mentor, a very aggressive, sometimes obnoxious chief resident that is talking through what they need to learn and how they need to apply it. It's our conclusion that enhancing communication is going to need similar coaching and mentoring from other members of the physicians that have prior experience that is useful, and certainly other members of the administrative team. We can't emphasize enough the value of mentoring about the value for performance appraisal and how that can enhance the effectiveness and career of the physician, and at the bottom line, patient care as well.
That's very true. Looking at towards the bottom of slide 23, having a direct tie to compensation is also a valuable action that respondents identified. And then having a clear job description was also a valuable action. And again, you've noticed this as being a theme mentioned throughout already in the survey. Continuing on slide 24, a few more valuable actions identified include having a disciplined reporting of time and activities, establishing a formal performance appraisal tool, education around the process, and Jim has touched on this already. Self-assessment is also a valuable action identified. Consistently used appraisal process, the same process applied year after year with enhancements made, but still consistently used throughout those years. 360-degree feedback process, mentoring by CMO, and then physician leadership training academies. And essentially, these findings reinforce our message that the industry and executive leaders would be wise to pay attention to these things.
Kate, we only have a few more minutes before we throw it open for questions with our colleagues on this webinar. It's clear that more needs to be done, and we need to find ways to raise the bar on the approach to physician performance planning, physician leader performance appraisal. Let's try and distill down some of the key conclusions that we've reached from these studies for our participants.
Sure, and so as the last piece of our webinar, we want to help sort of move you from the survey findings and leave you with some ideas that might help you move your current process forward to a more effective place. And one of those findings, and we've outlined this as 5 identified building blocks, would be make planning for the appraisal as important as conducting the appraisal. So have a job description available, and this is another theme that you've heard throughout. Use an agreed upon tool, because really you want buy-in from all parties on the tool being used. And then develop goals and expectations prior to the fiscal year so everyone's on the same page and it's understood what's being expected of them and what goals are being laid out. Sorry?
I'm sorry. I was going to say you're going to go to some positive motivations here in a moment, but I just want to make sure that our participants in this webinar realize there are some negative sanctions that are also a press for them to raise the bar in what they're doing for physician leader assessments. There is going to be an increase in IRS and CMS audits. And as they come in, if you're not able to demonstrate a job description and time reporting, and that this is being linked to appropriate compensation as well as results, you're going to hold yourself open for some substantial, not only embarrassment, but potential economic sanctions as well. So there are some negative things to avoid by taking a more effective approach to this, but why don't you comment? I can be the bad cop and talk about the negatives. Why don't you talk about what we're finding to be some of the positive reinforcers?
Including mid-year reviews with your immediate supervisor is also important. This goes back to the communication topic that was identified as being so important. Another, still looking at slide 25, building block that we identified and want to leave you with is having a purpose to support the leader growth and success of your physician leader. So therefore, use an incentive plan to leverage your organization's pay-for-performance philosophy and the appraisal process then to leverage growth and development of your leaders. The third building block that we've identified is utilizing the self-assessments as part of the process, because this will help identify gaps in what you understand to be the strengths and weaknesses of the physician leaders you're reviewing versus what they understand to be their strengths and weaknesses.
On that point, Kate, I was recently with a client, and the physician leader told me for the first time she really got it, that the board and the executive team cared about her development as a leader, not just on the clinical dimensions, but on leading groups, leading project and process improvement. And it really gelled for her when they said, we care enough to invest in your development and invest in helping you continually review what you're doing and how you can continually strengthen and enhance your performance.
Good point. And another positive then sort of building block that we've identified is conducting an annual 360 review process and not just having the superior review the physician leader, because the 360 review process will provide a much more robust process for not only the individual but for the organization as a whole, and the feedback is much more useful with a 360-degree review.
I think that's a very important point, Kate, and I'm sure our participants in this webinar have seen this happen. Nothing moves a physician's behavior more than input from their peers and colleagues. So If you just have a review where that physician leader is sitting down with an administrative partner or boss, if you will, you'll find much more acceptance and more positive behavior change when you get that peer input.
And the last building block that we've identified is to continue to revise and enhance your existing process. And this is necessary for the success of your physician leaders and ultimately for your organization's vitality. Really making strides in this area is, as we've said over and over again and want to leave you with, extremely critical for, again, the vitality of your organization.
Thank you, Kate. The survey, I think, is very timely as we are on the edge of huge change as we move into bundled payment and accountable care organizations, all of which will require physician alignment. The probability of having the kind of physician alignment we need for success goes up if we have effective physician leaders, and the probability of having effective physician leaders goes up if we are spending a more disciplined and rigorous approach on physician leader performance planning and physician leader performance appraisal. So we hope these ideas and insights are provocative for you. We hope that you will continue your own journeys to strengthen physician alignment and physician leadership effectiveness by raising the bar on how you look at performance appraisal activities for your physician leader colleagues. Let's see if we can respond to questions that have been coming in from our participants.
Okay, thank you, Jim, and thank you, Kate. Yes, we have had, multiple questions that have come in throughout the presentation, so we'll go ahead and get started on those and make sure to get as many in as we can. The first one that was submitted is, do you have any examples of a written appraisal form or tool?
Yes, we have both written appraisals as well as a web-based tool that we have developed. We can have samples of those available for those that have participated in the webinar. Many of them are adaptations of administrative assessment tools, but the style and wording and some of the content needs to have some revisions and refinements to make a closer embrace to the physician leaders.
And Jim, I should add too, we have both a paper survey available on the web-based appraisal, and what we're finding is many of our organizations choose to provide both of them to the users currently, and then we see organizations moving from that to then just using a web-based tool, but both are available and oftentimes both are used currently.
It's a good point. On the web-based tool, people participating in this webinar probably administer some of these appraisal processes. And the one advantage of the web-based tool is when you're getting peer input, you can quickly tabulate and report back the results of that. So it makes it much more efficient and therefore even more effective to communicate with the physician leader how they're doing and where they have opportunities to enhance their performance.
Okay, thank you both. Second question that we'll take is, our physicians seem reluctant to participate in administrative tasks like timesheets and performance appraisals. How can we convince them to participate? It's a good question.
It is a challenge. We continue to see that, and as we try to lift up physician leaders to be more professional and more accomplished in this area, I think the participants in this webinar will press up against that challenge a lot. There's no easy answer for it. We find that having serious invitations and recognition of their importance as physician leaders, communicated them by respected physician colleagues, by the board, in fact, of the organization, by the senior executives in the C-suite of the health system or the hospital, that helps. But what they have to really see is the personal value for them. There's both a carrot and a stick. The stick is if they don't use timesheets and performance appraisals in a more disciplined way, they expose themselves and most importantly, the organization to the sanctions of audits that are expected to come down from IRS and perhaps the CMS regulators as well. Some organizations try to moderate the imposition or the difficulty of this on the timesheets by assigning staff to help make sure the timesheets are filled out accurately and honestly and timely. And probably some similar hand-holding will be necessary to make it as easy as possible for them to do their self-appraisal as well as to invite in input from other administrative and physician colleagues. I think those dimensions, Kate, are going to be helpful aspects to overcome this inherent inertia to do, quote, administrative tasks.
Okay, thank you, Jim. Our next question is asked by Anthony, and he asks, we are developing 2 new physician leadership/executive positions with no existing job descriptions. Where does one start in generating de novo job description? Are there templates?
We have developed 90 different physician leader job descriptions. Many of them have probably 70% core accountabilities to them, and they vary between emergency department medical directors for rural outreach, for referral physician management of those relationships. So there are a number of samples that are available. If the person asking that is not working closely with the senior human resource people, we would certainly encourage you to sit down and build that kind of rapport, because oftentimes the HR people are not involved enough in designing and carrying this out. They are the last ones to be invited in, and we believe they should be the first. So also you can turn to some of the medical specialty societies are starting to publish information relevant for administration of physician leadership positions, and the American College of Physician Executives is starting to make this information available. So we can provide some samples to those that have participated in this. If you have follow-up questions, please get back to us on that.
Wonderful. Thank you, Jim. Go ahead and move on to our next question here. And Eric asks, do you recommend the same approach for those physician leaders that are not full-time physician leaders, but are clinical 75% of the time and administrative 25% of the time?
I'll let Kate help on this as well, but the discipline and the value of performance appraisal doesn't change whether you're part-time or full-time. So the same rigor and sense of focus on the growth of that individual is very important. In fact, it's probably more important and also more difficult to do it for the part-time physicians. We recently worked with a client that wasn't sure how many physician leaders they had, how many they were paying, how much they were paying, and we found out in an analysis and plotting out these physician leader relationships that they had over 90, and they were spending close to $8 million. And so it's a big deal, and many of those, the vast majority, were part-time. So I believe, Kate, the same discipline should be applied both to part-time, full-time. What do you find, and what do you feel about that?
Well, we see this quite common with our clients, and the reverse is true, where a lot of them are involved in administrative activities for 75% of their day, and then 25% clinical. So, and then we see 50-50 split with their activities and responsibilities. And our solution to that is really to customize a tool for them that's appropriate to their organization and their particular job descriptions. And so we approach this as quite an in-depth process of discovering the appropriate tool, again, for a particular organization, whether it's weighted more heavily for administrative activities or clinical activities. But like Jim is saying, it's still vitally critical to capture all of the responsibilities in the tool that's being used, even if there's only a 25% activity around administrative duties.
I agree with that, Kate. In fact, when the IRS comes in, they're not going to care whether they're full-time or part-time. If you can't demonstrate that there is some rigor to actual job descriptions, that you're able to account for the time that's invested, they are going to add up all of the time. And if you find that you've got 50% administrative on this task, and they happen to be an employed position, which is 70%, and another medical directorship that's part-time for 30%, if they add all that up and it's more than 100%, and you're paying them more than the market would justify for that 100%, you're going to expose yourself to substantial penalties. So there's another motivation for giving high focus to this, whether full-time or part-time.
Okay, thank you both. This is an interesting question. Why not do performance appraisals for all physicians as well as physician leaders? Do any organizations do both?
Yes, it does occur. In the United States, some of the large multi-specialty group practices do expect, as a part of employment, that every physician have some performance review. Here in the Minneapolis-St. Paul area, there's a large respected organization called Health Partners. They expect whether primary care or family practice or specialist physicians have to have an annual review. In some of the larger organized systems in other countries, we've found in my work at the business school at Cambridge University in England that the National Health Service and the Canadian systems all have web-based tools for regular physician performance reviews. In fact, they lag behind the adaptation of the clinical performance reviews to the physician leader administrative responsibility reviews. So I think the short answer is yes, there are a number that are using it. It's not as well established in the U.S., but the more we move to integrated models, the more we can expect those physicians as senior and respected employees to demonstrate continuous growth and development, and that can be nurtured by an annual performance appraisal.
Thank you, Jim. Looks like we still have some time here. I'm going to go ahead and start by taking one more and then see how we do on time. Who do you see driving this process at an organization, either getting it initiated or further developing it?
What we see as most effective is really it being driven by the CEO and the senior executive team, and Jim mentioned this briefly earlier on. But what's also critical or important in getting the process established is having the senior HR person help establish the process and really research the tools that should be used, and also research and develop the process that should be used, and then funnel that to the CEO and the senior executives to get their buy-in, and then again, they really drive the process. But this again, the common individual that we see help really put this together is the senior HR person. So all in all, it's a team effort, but there are individuals who are taking different pieces of this effort.
Okay, thank you, Kate. We are coming up on the end of our time here, and we have a few closing comments and some wrap-up instructions we'd like to go over with our attendees. So that's all the questions we're going to take today. If your question did not get answered, please be assured that we will be getting back to you personally via email or a call to that participant to make sure that their question did get answered. On your screen, you can see that we've had up contact information again for our speakers. If you have further questions or would like to have a discussion with either of them, please call or email them directly at the information you see listed. Following today's webinar, as I've already noted, all registrants will receive a copy of the slide presentation, and then in a few days, a recording of this webinar will be available on the Integrated Healthcare Strategies website. You just want to go to our homepage, ihstrategies.com, and then navigate to our Knowledge Center, and you'll find that recording along with other resources like articles and white papers at this location. I want to thank you all for joining us and hope you have a great rest of the day.